So at this IMS meeting, I had the privilege of presenting the first look of part 1 of the DREAMM-20 study of Belantamab in patients with a relapsed refractory multiple myeloma. Now, to set the scene, Belantamab is not the same as Belantamab mafodotin. It is a monoclonal antibody that's naked, targeting BCMA, and unlike Belantamab mafodotin, it is not conjugated to the monomethyl auristatin F that is thought to correlate with corneal toxicity. So in the DREAMM-20 study, we enrolled patients who were triple class exposed and had at least 3 prior lines of therapy. Prior BCMA targeted therapies were allowed. Belantamab was given intravenously on days 1 and 15 every 28 days until disease progression in escalating dose of 300 milligram, 900 milligram and 2000 milligram, and treatment was until disease progression. 18 patients were enrolled, 6 in each of the 3 dose escalation. And these patients were heavily pre-treated with a median of 4 and up to 18 prior lines of therapy. So what did we see? Belantamab, from an efficacy point of view, is very well tolerated. The most common adverse event was infusional reaction that occurred in only 4 out of the 18 patients, so 22%, but all these were mild. They were easily manageable by paracetamol and did not recur again upon re-challenge. Hematological toxicities were low. Neutropenia, anemia and thrombocytopenia only occurred in a handful of patients, and there was no significant signal at all for infections. What about corneal adverse events that everyone seems to be talking about? Well, interestingly, we saw 2 patients with grade 2 or more corneal adverse events, but neither of these patients were attributed to Belantamab itself, and in fact, the corneal adverse events improved spontaneously and did not recur upon re-challenge with the same dose of Belantamab. And all the other lower grade corneal findings seems to be reflective of the baseline corneal abnormalities that we see in elderly patients as opposed to treatment-related toxicity. In terms of efficacy, we saw responses in 5 out of 18 patients, giving an overall response rate of 28% with a VGPR in 3 patients. But what was really striking was the durability of response. 4 out of these 5 patients responded for over 1 year, including 1 patient who is still responding more than 1.5 years on. There was 1 patient who stopped treatment after 6 months, having achieved a VGPR, and that was out of her own choice. And so just to summarize, even without the monomethyl auristatin F payload, Belantamab still demonstrated meaningful efficacy in multiple myeloma, and with very favorable safety profile, in particular no treatment-related severe ocular toxicity and no significant signal for hematological toxicities or infections. The DREAMM-20 is currently underway, exploring the combination of Belantamab with Belantamab mafodotin, leveraging on the clinical activity of Belantamab to allow us to perhaps using a lower and less frequent dose of mafodotin with the overall aim of improving outcome and minimizing the corneal toxicity. Now, I think it's really early days, but it is exciting, and I think it does open up new possibilities for BCMA targeted therapies in multiple myeloma.